Hi, good afternoon, everyone. It's 12 o'clock on the dot at the moment, so I'm going to give an extra couple of minutes just to make sure that everyone's actually here, and then we'll get started. It's certainly a very busy turnout. We have 63 already. So give it, as I say, we'll give it another minute and then we'll get started if that's okay, Dr. Qureshi.
Absolutely, that's fine. Good.
Absolutely. Yeah, so we have 94 anticipated guests, so we're at 72 already. I'll just a little bit longer, then we'll kick off. Certainly still climbing as we speak.
I think we've got about half an hour or so, Alistair. Is that
yes,
roughly
yes,
right?
Dr. Qureshi, about half an hour for you to speak, and then at the end, if there's time allows, maybe 10 minutes for questions, maybe 5. Just we'll have to see how it goes, but
sure,
absolutely. Now, that is 2 minutes past. We're at 75 attendees, so I think we'll just get started. A very good afternoon to you all. My name is Alistair Barber. Thank you all very much for attending today's webinar, which is part of our series of monthly webinars, which will run throughout this year. I am delighted today to be able to introduce Dr. Yamin Qureshi, a consultant psychiatrist who has agreed to speak in relation to the subject of psychiatric illness in the context of legal claims for personal injuries. As I'm sure we're all aware, claims involving a psychiatric illness component can be very challenging to investigate, which is why, of course, we rely on experts such as Dr. Qureshi. Dr. Qureshi will provide us with his insights in relation to the diagnostic process and speak about the mental health conditions most often encountered when dealing with claims of this type. Now, by way of a very brief introduction, Dr. Qureshi regularly provides medical legal reports and gives evidence as an expert witness at court, at mental health tribunals, and also to statutory bodies such as the Nursing and Midwifery Council and the GMC. He is a health examiner and medical advisor to the GMC, and he is also a medical advisor to the General Dental Council. Dr. Qureshi has a specialist interest in the treatment of drug and alcohol addiction. Now, finally, before I hand over to Dr. Qureshi, this is just a reminder that today's presentation will be recorded. Dr. Qureshi has provided a number of slides which he will refer to, and these will be controlled by my colleague Michael. At the end of the presentation, there will be about 10 minutes for questions. This looks to be a very interesting seminar, certainly if the numbers are anything to go by. And Dr. Qureshi, over to you.
Thank you very much, Alistair. Thank you. So, Michael, first slide, please. So thank you all very much for joining me today. My name's Dr. Qureshi. I'm a consultant psychiatrist, as Alistair's mentioned, and I am sort of increasingly involved in sort of various medico-legal matters, and balance that off with my clinical work as a general adult psychiatrist and an addiction specialist at the Priory Hospital in Glasgow. Michael, next slide, please. So the origins of this talk really are founded in some of my own experiences, actually. I sort of went to medical school in King's College in London, did fairly well, sort of enjoyed various blocks, including psychiatry, then completed my house jobs and thought it would be a good idea to get more experience in psychiatry, started work in psychiatry, and found it sort of incredibly difficult, despite all of that training, to sort of even sort of make rudimentary diagnoses. I can only begin to imagine what it's like for lay people trying to understand what we do. And in essence, this talk is what I wish I had have known back then at the start of my psychiatric career, and what I think would be tremendously helpful for legal professionals to understand. So a really good place to begin with would be how do we go about making diagnoses in psychiatry? And in essence, in psychiatry, we have, broadly speaking, 5 categories of diagnoses, and those are organic illnesses, psychotic illnesses, mood disorders, anxiety disorders, and personality disorders. And it's really important to think about these in a quite logical way. And we have something called the psychiatric or diagnostic hierarchy, which in essence means that one has to begin from the top of that list and work downwards. Otherwise, you're at risk of missing conditions or making the wrong diagnosis. So next slide, please, Michael. So top of that list is what we call organic conditions. And the clue what those are about is in the name. So those are to do with organ systems. In essence, physical illness can cause mental health problems or psychiatric conditions. So when one thinks along the lines of organ systems, for example, there's neurological conditions that can affect a person's mental health, things like concussions, delirium, dementia, tumours, endocrine illnesses such as thyroid problems can cause mental health issues like anxiety disorders. Cardiac issues can also cause mental health issues. For example, mitral valve problems in the heart are associated with panic disorder, not commonly sort of known. Infections can be associated with a whole raft of mental health issues such as psychotic illnesses, and then drugs and alcohol can be associated with all manner of problems as well. Next slide, please, Michael. So you may hear the term psychotic illness sometimes mentioned, and it actually took me quite a long time to understand, well, what exactly is a psychotic illness? It sounds really serious. And in essence, a psychotic illness is when a person is no longer in touch with reality. And it's characterized by 2 main symptoms: delusions and hallucinations. And I'll come back to those a little bit later, what exactly those are and the significance of those. But in essence, there's broadly speaking 4 subdivisions of a psychotic illness, and we've got schizophrenia, schizoaffective disorder, which is where there's symptoms of schizophrenia and a mood disorder simultaneously present within the illness. And then there's acute and transient psychoses, and that's what's traditionally sort of in lay terms referred to as a nervous breakdown. And then we've got delusional disorders where the sort of overriding feature is actually just a delusion of some sort. Next slide, please, Michael. And then after that, we've got affective illnesses, and affective essentially means mood. So these are disorders where the mood is the primary issue. And broadly speaking, your mood can either go up or it can go down. But the duration and the severity by which it changes, it is important in terms of making the diagnosis. So if there's a slight elevation of the mood and that's a chronic problem, then that's a condition referred to as dysthymia. And then beyond that, there's sort of mild, moderate, and severe categories of depression. And if a depression becomes very severe, person can actually become psychotic, but it's still categorized as an affective illness. So that's when the mood goes down. A person's mood can also become elevated, and in essence, that is referred to as either hypomania or mania, when there's mood changes in that direction which are sustained. And that's very often sort of seen in a condition called bipolar disorder. There is another mental health condition called cyclothymia, which is where the mood changes are not as severe as occur in bipolar disorder. Next slide, please, Michael. So beyond the mood disorders, we've got a group of conditions which are that's anxiety disorders. So again, anxiety is the overriding feature here. And that includes conditions like obsessive compulsive disorder, generalized anxiety disorder, panic disorder, PTSD, post-traumatic stress disorder, phobic anxiety, and adjustment disorders. And the last three of those, I think, are particularly important when it comes to personal injury claims. So I'll mention and speak about those in a little bit more detail. Next slide, please, Michael. So a little bit about sort of anxiety type symptoms. Anxiety symptoms can be psychological, where there's restlessness, a person feels on edge, there's a preoccupation with whatever has caused the anxiety, and there can be avoidant behavior, but also anxiety symptoms can be quite physical and sort of manifest as sweating, shaking, nausea, dizzy, dry mouth, and palpitations. And when one is doing an assessment of an anxiety disorder, one does drill down into exactly what symptoms there are, and those can be significant in terms of the diagnosis. Next slide, please, Michael. So phobic anxiety, this is something that's quite sort of commonly seen in claims. And in essence, what happens is that a certain situation becomes quite intrinsically associated with anxiety. If somebody's involved in a serious road traffic accident, then they subsequently have difficulties or can have difficulties getting back into a car. And what one sees in phobic anxiety, so quite so classically, is that the anxiety is restricted to that situation. So it's triggered if there is contemplation or sort of a person's actually in that situation, and then when they're no longer in that situation, the anxiety goes down. So that pattern is really quite important in terms of a diagnosis of phobic anxiety. Next slide, please, Michael. Adjustment disorders. So again, the clue about what an adjustment disorder is about is in the name. In essence, there is some kind of trauma or traumatic sort of incident, and then the person has difficulty adjusting to normal life after what has happened, and in essence, an adjustment disorder, there can be sort of a really broad range of symptoms, but the key thing with most adjustment disorders is they rarely persist for more than 6 months after the stressor or its consequences have resolved. The symptoms that happen are clinically significant, and there has to be some degree of impairment of functioning. And a lot of people think about adjustment disorders almost as sort of subclinical manifestations of other sort of mood and anxiety disorders. Next slide, please, Michael. And in terms of management of an adjustment disorder, sometimes some form of supportive psychological therapy can be helpful. Pharmacological treatment is rarely needed. And I've made a note there at the bottom in relation to an adjustment disorder. It can be really difficult to dispute the presence or absence of an adjustment disorder in a defender report. And the reason is because of the very nature of an adjustment disorder. It happens and then it's resolved within sort of around 6 months. So just something to bear in mind there. Next slide, please. Post-traumatic stress disorder, again, a condition that no doubt many of you will be sort of familiar with, and PTSD is characterized by a range of symptoms, re-experiencing the trauma in the form of flashbacks and nightmares. There can be hyperarousal with hypervigilance, anger, irritability, emotional numbing and detachment from social supports, negative alterations of mood and thinking, negative self-perception, where there's a sense of the person being diminished or defeated or worthless in some way, avoidant behavior, dissociation and interpersonal difficulties. Next slide, please. So with PTSD, the onset of the symptoms classically are within sort of 6 months, and very important to bear in mind that to make a diagnosis of PTSD, there needs to be a really quite sort of extreme event or trauma which is out with the bounds of normal human experience. There can be sometimes a delayed onset beyond that 6 month period, and around 10% of people sort of experience that. And in terms of percentages, after a really significant psychological trauma, around 8 to 13% of men and between 20 and 30% of women develop sort of PTSD symptoms. And the risk factors include female gender, low self-esteem, pre-existing psychiatric difficulties, and past trauma as well. And the important thing that I sort of reiterate, certainly with my clinical hat on to my patients, is that it is a treatable condition for a significant proportion of people. Next slide, please, Michael. So you may hear this term complex PTSD, which can be quite confusing in that it sounds like it's a more severe form of PTSD, which in some ways it is, but the essence of complex PTSD is where there's repeated trauma over an extended period of time, or from which it's difficult to escape. So things like torture, abuse, genocide, and sort of other forms of trauma, really. Next slide, please, Michael. Just wanted to say a little bit about somatization. So somatization is a really sort of interesting condition. This is where there is the conversion of mental distress into physical symptoms. And we're not completely clear about how or why that happens, the theories are that there's sort of unconscious processes at play here that lead to that process, and people are not putting on the physical symptoms. They sort of genuinely experience them. And in somatization, you get repeated presentations to doctors for investigations and what's called sort of fat file syndrome. So patients can have really sort of significant medical records that date back many, many years. They've had numerous investigations and not related to a single bodily system. Next slide, please, Michael. And in somatization, the patients tend to minimize all but the most recent symptoms, and their entire life can revolve around the perceived illness. And it's a really difficult diagnosis to actually make, but the key is multiple atypical, medically unexplained and inconsistent symptoms in a patient who's under the age of 40. So one does need to take a really sort of longitudinal view about this, and 2/3 of such patients meet the criteria for another psychiatric disorder as well, usually depression or anxiety, and they sort of quite characteristically deny that there's an underlying sort of psychiatric condition, or alternatively, the conversations along the lines of, well, the only reason I'm depressed is because of pain. And the sort of significance of somatization is it can be quite difficult to tease apart from other conditions like health anxiety. But in health anxiety, you don't see this very, very long picture. And in health anxiety, a patient is preoccupied about the possibility of having a serious illness, but there is transient sort of relief from medical reassurance or sort of investigations, and that's not the case in somatization. Next slide, please. Wanted to say a little bit about the significance of pain when it comes to sort of mental health conditions. So in essence, there is a bi-directional relationship between pain and certain mental health issues. Pain can cause depression and anxiety, but depression and anxiety can exacerbate a person's experience of pain. And very often in sort of reports, you may see the medical specialist saying that there's some kind of psychological overlay, and that's sort of relevant for a number of reasons, but perhaps most importantly, that second point, which is that depression and anxiety can exacerbate the pain, but then easily missed. Next slide, please. Also wanted to say a little bit about the sort of significance of alcohol. The current government recommended limits for sort of weekly alcohol is 14 units, but sometimes in some patients, especially if they've experienced some kind of injury, there can be sort of a degree of self-medication through alcohol. There are associations between excessive alcohol consumption and various sort of mood and anxiety disorders, including post-traumatic stress disorder. So always worth thinking about sort of the significance of alcohol. A commonly used screening questionnaire in primary care is the CAGE questionnaire, and that's essentially stands for, do you feel that you should cut down? C for cut down your drinking. Do you get annoyed? A for annoyed. If somebody speaks about your drinking, do you feel guilty? So G for guilty about your drinking. And E, do you ever need an eye opener in the morning to sort of stabilize yourself? If there are concerns about sort of alcohol dependence, then patients need a formal sort of detoxification, either through primary care or through an addiction specialist. When it comes to alcohol, and if somebody is genuinely dependent on alcohol, it can be very, very dangerous to stop drinking abruptly. In some ways, perhaps one of the most dangerous sort of forms of addiction of all of them. Next slide, please, Michael. Just wanted to say a little bit about psychometric tests. These can be really quite confusing when you read them in a report. So in essence, psychometric tests try to quantify symptoms so that one can screen for the likelihood of certain mental health conditions. The commonest ones that I come across are the PHQ-9, the Patient Health Questionnaire 9, and in essence, that's a screening tool for depression. It's got 9 questions scored on a Likert scale of 0 to 3. The generalized anxiety disorder 7, GAD 7 questionnaire, 7 questions, again scored 0 to 3 on each of those. The impact of events scale, which is 22 questions. And the important thing to remember with psychometric tests is that they're screening tools, they're not diagnostic tests. And in some ways, the real value there is trying to measure change and improvement over the course of a condition. Next slide, please. I'm going to move to the next slide, mindful of time. Next slide, please, Michael. Just wanted to talk a little bit about suicide. So in terms of suicide, sometimes, especially in certain conditions, there's sort of significant concerns and risks. Asking about suicide doesn't cause it, and there is a difference between passive nihilistic thoughts and active intent, and that's something that is often sort of explored by psychiatrists when assessing somebody, and not everybody who commits suicide is sadly mentally unwell. Next slide, please. A little bit more about suicide. So although women are more likely to attempt suicide, men are more likely to die by suicide, and so there's increasing risk with advancing age. There's almost sort of 2 peaks. The first peak being in middle age, and then sort of peak again in sort of older adults as well. And risk factors for suicide include sort of divorce, widowed, and there is something about being married that seems to protect against suicide. Certain professions are at increased risk, vets, pharmacists, farmers and doctors. Social isolation is important, and if there's a sort of previous history, that can be associated with increased risk, as well as a range of mental health conditions as well. Next slide, please. When would I worry about risk of suicide? Well, if there's a direct statement of intent, more violent methods, if somebody is talking about sort of hanging, jumping or shooting, which you tend to find is more sort of common amongst men, you would worry more. If there's a significant mood change for any reason, feelings of hopelessness, personality difficulties, social isolation, those are sort of really sort of significant risk factors, and there is always somebody available. So the GP, there's an out of hours GP, and the casualty department as well, if there's any sort of significant concerns, as well as sort of specialist services like community mental health teams. Next slide, please, Michael. And in certain cases, mental health legislation does have to be used. You may sort of come across these terms, emergency detention certificate, and that's when there's sort of significant concerns, and a person needs to be detained in hospital for assessment for up to 72 hours. And then beyond that, there's consideration of extending that, in which case we use a short-term detention certificate, which lasts up to 28 days. And then there's other forms of detention as well for sort of really severe and enduring mental illnesses. Next slide, please, Michael. A little bit about prognostic factors when it comes to thinking around mental health issues. So first of all, one has to think around the severity of the psychiatric injury in the first place, its progress over time, and that's where psychometric tests really can come into their own. The person's age, the degree of loss, the degree of social support, and response to medication and psychological treatment as well. Next slide, please, Michael. A little bit sort of specifically about PTSD and prognosis. Now, approximately 50% of individuals with post-traumatic stress disorder recover within 12 months, but around 30% experience a much more sort of chronic course. And the outcome in PTSD does to some extent depend on the initial symptom severity, recovery being helped by things like good social supports, a lack of negative responses from others, no maladaptive coping mechanisms such as the misuse of alcohol, no further trauma, no disfigurement, and if there's no sort of disrupted relationships, financial problems and litigation can be very, very difficult for patients as well. Next slide, please, Michael. A little bit about sort of terminology in sort of mental health issues. So delusions are when people are thinking about things that aren't true, and we refer to the 3 Fs, which stand for fixed, false, firmly held beliefs. Hallucinations, in essence, when people experience things that aren't there, and hallucinations can happen in any of the 5 senses, but in psychiatric disorders, we're particularly interested in auditory hallucinations, so hearing things that aren't there. The other types of hallucinations, i.e. visual, tactile, olfactory and gustatory hallucinations, are normally indicative of physical health conditions like epilepsy and tumours, and not primary psychiatric disorders. But auditory hallucinations, if those are present, then one does think along the lines of it being a primary mental health issue. And the nature of those auditory hallucinations is really quite important as well in terms of diagnosis. So second person versus third person auditory hallucinations. And what I mean by that is voices talking to you as opposed to voices talking about you. Can be very important as well. So in a depression with psychotic symptoms, you generally get second person auditory hallucinations, so voices talking to you. Whereas in schizophrenia, i.e. a psychotic condition, you get third person auditory hallucinations where voices are talking about you. Next slide, please. A little bit about psychologists and psychiatrists, really quite confusing, but in essence, psychiatrists are sort of medically trained and involved in the sort of assessment and diagnosis and treatment of the sort of full range of those 5 key categories, from organic all the way through to to personality disorders, and some psychiatrists have specialist training in psychotherapy as well, and are involved in medical interventions as well as psychotherapy, whereas psychologists have sort of special sort of experience in delivering a range of talking therapies, including cognitive behavioral therapy and EMDR as well, and also sort of specialist training in psychological testing and evaluation, but they don't really get involved in prescribing medication or requesting investigations. Next slide, please, Michael. Finally, just a little bit about my sort of experience in terms of sort of medico-legal work. Good instructions from solicitors are tremendously helpful, and the reason for that is very often, before I've even sort of seen a client or a patient with a good history, I've got a really good idea about what's going on, and then sort of actually seeing the client means that I can test that hypothesis, and specific questions from the sort of instructing party again really help to focus and hone in on the key areas. And as sort of mentioned at the end there, litigation it is tremendously difficult for patients, but also it's so important in terms of any sort of mental health issues that they have, that there is this sense of justice being had, really. So I think that's significant. Next slide, please. Couple of useful sources of information, really helpful books. So Crash Course in Psychiatry by Katie Marwick and Psychiatry by John Geddes, really helpful. Next slide, please. Thank you very much. Happy to take questions from anybody.
Thank you very much, Dr. Qureshi. That was excellent, very comprehensive, and I certainly found that to be a very insightful talk. As Dr. Qureshi has said, we now have some time for questions. Over to you guys if you have anything to ask. I think certainly one of the things I would like to ask you about, Dr. Qureshi, is very often I encounter we'll have a situation where an individual claims for psychiatric harm, but there are no attendances at their GP. Now, that happens quite often, surprisingly often. I just wonder, I mean, say there's been the passage of a year or a year and a half between the incident, let's call it a road traffic accident, and there have been no attendances in relation to any psychiatric symptoms. What can you take from that? Is it a simple interpretation, or is it a bit more complex?
I think one needs to be really quite careful in that situation. The absence of engagement with a GP doesn't necessarily translate to there being no issues. I'm thinking sort of phobic anxiety. Somebody's been involved in a car crash, and sometimes they don't completely make the link that actually I've got a medical treatable condition here that I need to see my GP about. Tremendously difficult to get appointments with a GP. My wife's a GP, so I'm very aware about that. And sometimes people just don't think, well, it's not necessary. And the other one being an adjustment disorder as well, really. So the symptoms are there. People try to get on with sort of normal life, and the absence of any sort of engagement with a GP. I think one needs to be quite careful, really.
Yes. Yeah. Okay, excellent. Thank you very much. Now, I've got a couple of questions which have popped up. The first one is from Vicky. Thank you very much, Vicky. What is the true definition of a nervous breakdown? What is meant by this? Is it burnout?
That's a very good question, and after all of these years in psychiatry, I'm still not completely sure is what I would say. It's a sort of a lay term, a nervous breakdown. To my mind, it's almost, well, an acute and transient psychotic disorder, but it could be sort of anything from an adjustment disorder to a severe mood disorder to a psychotic illness, and in an acute and transient psychotic illness, again, the clue is in the name. There is almost something that snaps in the mind, and people can actually become psychotic through sort of intense stress alone.
Okay, excellent. And the next question is from one of my colleagues, Claire. Why is being under 40 important in making a diagnosis of somatization disorder?
Okay, just to clarify, it's not important. It's not important to be under the age of 40 to make that diagnosis. But what is significant is that as we all get older, the chances of us having physical conditions increases. But if you've got somebody who's under the age of 40 and they've got a huge file and they've seen lots of different doctors from lots of different specialties, and nobody has actually given somebody a diagnosis, then you start to think along the lines of somatization, really.
Excellent. And we have a very interesting question, certainly one that was at the forefront of my mind during the COVID restrictions. Do you feel that remote examinations are of any value? Thank you very much for that question, Michael.
That's a really, really good question. Now, I do sort of medical legal assessments for both pursuers and defenders as well. Short answer: when it comes to sort of psychiatry, yes, you can, because a physical examination is not necessary. That said, especially for sort of defenders, I do like to see my clients in person, actually, because I think you can miss some subtleties in terms of body language and so on and so forth if someone's not in the room.
Yes, absolutely. Well, that's very helpful. That's also a very good point, actually. So would I take it then the physical examination in person is probably the optimal, if possible?
I think so. Yeah, I certainly, again, with my clinical hat on as well, I much prefer to see a new patient in person. I think you get a much better quality of assessment. If again, very much with my clinical hat on, if I've seen somebody in person initially and I don't have huge concerns about them, then I'm happy to see them remotely. But if I'm concerned about somebody, I would much rather see them in person. And that's just the way that I do things.
Absolutely. Ideal. Now, I don't see any further questions at this point, and that's almost bang on 45 minutes, which is the allocated time. So unless there are any additional questions, yes, thank you, Karen. We can share that out. That's no problem at all. With Dr. Qureshi's permission, of course. Now, unless there are any further questions anyone would have, I think we would all wish to thank Dr. Qureshi for taking the time to speak today. And that about wraps it up. We have another seminar which is due to take place on the 19th of March, subject matter to be confirmed, but the invites will be issued in due course. And we hope to see you all then. Enjoy the rest of your day. And Dr. Qureshi, thanks again. That was an excellent talk. Thank you very much.
Thank you very much, all. Thank you for inviting me. Bye-bye now. Thank you.
Thanks.